Good afternoon. I'm President Catherine Rowe, and it's such a pleasure to be with you today. I want to thank our host, the Society for 1918 and the Hulan Willis Association. Today's program launches a new series focused on women's health, and we'll have offerings throughout the spring. I hope you will continue to tune in. It's a fascinating series. I want to start things off by saying it's an honor and it's a little bit daunting to be starting us off on the topic of women's health when there are some lions in the field, in the room, in the virtual room with us. I see Sybil Shainwald, who has been responsible for one of the groundbreaking rulings to protect women's health in the 20th century. Great to see you, Sybil. I believe Lisa Roday and other members of the board may be here. I hope they will drop a shout out in the chat. I do encourage you to use the chat because that adds so much richness to the conversation. This is an incredibly timely moment to be expanding our thinking about how to improve health for women and about the role of higher education in that pursuit. We are deep in pandemic still, but we are also feeling some hope as vaccines roll out. We are so grateful to our friends and our trusted leaders in the Department of Health here in Virginia for that incredible effort. We're starting to take stock now because we can begin to see light at the end of the tunnel of what has worked, what has not worked, what we have learned about how to keep a community well. As an institution that's committed to fact-based inquiry, evidence-based decision-making, William & Mary has a responsibility to disseminate knowledge and combat misinformation, and that has never been more important in my lifetime than this year. We have been making decisions here in a data-driven way, and that has been vital to the university's success under pandemic. So we've been thinking a lot about what it means to be working side by side with experts in health, in public health, in epidemiology. At William & Mary, we have a public health advisory team that's made up cross-sectionally of faculty epidemiologists, physicians, and testing experts, folks in our IT group, who are able to implement a testing regime that's constantly changing with new evidence about what works. They engage with the data from campus that we're seeing multiple times a day to adjust our approach. And that advisory team is the broader community as well, in the campus community, living in the region, part of our neighborhood, part of our localities. They are thinking always both for William & Mary and for our larger region, because we see ourselves and our own health as inextricably intertwined with that larger region. We've been blessed with robust partnerships here in the Williamsburg area and with the Commonwealth, and we have an incredibly caring community that has embraced public health safeguards like I think maybe no other community in the United States on a university campus. Each time students have returned to campus, the positivity rate has dropped in our localities markedly. Now, I know some of you will say that was bound to happen in January, but it was not bound to happen in August. We know some of those shifts are national trends, but some of it is truly attributable to the way that this campus and our students and the town have bonded together in shared commitments to each other's health. On campus, 97% of our students have been wearing masks. And from August to now, you have seen dramatic changes in the habits in town as well, and mask wearing. The ethos of this student body is something that I learned early on from our moderator, Rachel Becker, William & Mary member of the class of 2019. She put forward in front of me in a board meeting a very simple and very powerful statement when asked what distinguishes William & Mary students. Rachel, do you remember what you said? You said, we take care of each other. And that has been our mantra for our region, for our state, our Commonwealth, and for our campus this year. I give you that prologue because we know that COVID-19 is not the only public health crisis that we face now or will face. As a nation, we see incredible disparities in maternal mortality. This topic is very close on a personal note as a mother, as a daughter, as a sister. Maternal deaths have risen in the United States since 2000. 2/3 of those deaths are preventable. In 2019, CDC researchers reported that Black, American Indian, and Alaska Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women. Just think of those numbers. William and Mary confronts these facts as a learning community, seeking to understand and to change the world for the better, change those conditions on the ground, near and far. Our mission is to train the next generation of professionals and compassionate human beings who are thinking in both and terms. Students who draw on the breadth and depth of the liberal arts, who pair quantitative fields like biology and chemistry with data science, with economics, with ethics, with philosophy, with gov, with humanities to address the pressing challenges that we're facing right now. Where if any of you heard Dr. Anthony Fauci in our interview just about a month ago, I asked him what had made a difference in his undergraduate education. He said, oh, it was the classics, which were the best preparation for life as a physician. It was a wonderful moment. We're fortunate today to be joined by experts leading efforts to reverse the trends in maternal mortality, including our keynote speaker, First Lady of Virginia, Pamela Northam. Mrs. Northam is a former science educator and a pediatric occupational therapist, as well as a mother of 2. As her son Wes graduated from William and Mary in 2010, and as the First Lady of Virginia, her policy efforts have been focused on early childhood education. She takes an approach to school readiness that begins in utero. Mrs. Northam has held listening sessions around the Commonwealth with hospitals, midwives, teachers, OBGYNs, and doulas. Since 2018, Mrs. Northam has chaired the Northam administration's Children's Cabinet, which brings together expertise throughout the state government in order to increase collaboration. Over the past year, she's played an important role as the Commonwealth has navigated the greatest public health challenge in over a century. Just about a month ago, I was speaking to her on the phone and she reminded me for our Williamsburg, James City County Clinic to think about the daycare centers that were independent, not just the ones that were affiliated with schools where we had already vaccinated the staff. And Mrs. Northam, you'll be happy to know I took that right back to our clinic the next day and we have that covered. So we are so grateful that you have joined us today. Please join me, everybody, in welcoming the First Lady of Virginia, Pamela Northam.
Good afternoon, everyone. Thank you, Dr. Rowe, for your kind introduction. We so appreciate the amazing work that William and Mary does, building the leaders of tomorrow, and we certainly need them, as you know. And I love that you spoke about being evidence-based, flexible, and visionary during these difficult times. And my goodness, William and Mary has been long enough to prove it. That's a recipe that works. So it's always an honor to be with William and Mary. And as you mentioned, my son Wes will soon be finishing his pediatric neurosurgery fellowship with Harvard at Boston Children's. And he gives much of the credit of how well he's doing now today for his time from his time at William and Mary. Many happy hours, he says, spent in Dr. Allison's lab with genetics research. So please give her a pat on the back and shake her hand for us. I'm so delighted at the opportunity to speak to a community today that has a special place in my heart about a topic that is also close to our hearts and one that our administration considers a top priority. Thank you to Dr. Hammond, Professor Mckinney, Dr. Walker Harris, and Kelly Cannon for your outstanding service to the Commonwealth and for taking the time to be on this expert panel today. I hope you all the many of you that are joining us today, I hope you had a happy International Women's Day yesterday, celebrating those on whose shoulders we stand today, like amazing Sybil Shainwald that I'm so thrilled is joining us today, and the young women who will change the world of tomorrow. It also happens to be my daughter's birthday. She's also amazing, a woman who codes. She's a web developer making websites and apps, and she's pretty amazing, but I often call her my pearl of great price. She was born while we were stationed overseas during the Gulf War, and I recalled her birth when thinking about this discussion today. Not only did she manage to be late, which she still often is, and breach, I will never forget feeling so vulnerable and alone without community in a foreign hospital where things were so unfamiliar and frightening. where their medical procedures and cultural traditions were so different from mine, and where I struggled to be heard and understood. I'm grateful for that experience. It gave me a small but valuable insight to the unbelievable challenges that so many women face in maternal fetal medicine across the world, and still to this very day. It is one of the many reasons that this work and our discussion today are so important to me. When I started in pediatrics and therapy, we were just beginning to help in the NICU. And later I did high-risk infant follow-up with home visits, where I saw firsthand the incredible benefits of early intervention and postpartum support. It's shocking and appalling that since women came to William and Mary in 1918, we have made such little progress. As my fellow First Lady, Michelle Obama, said, the measure of any society is how it treats its women and girls. There is no time to waste in addressing this disparate health outcome, especially for our mothers and babies of color. The governor and I have always believed that there is great power and potential in every child, that each and every one deserves the very best start in life. They are the most important asset we have and the best investment for our future. Much of my policy has been mentioned, much of my policy work has been improving access to early childhood education. But the more we learn about brain development, the clearer it is that school readiness for our littlest learners starts even before birth. So last fall, our administration traveled over 5,000 miles to 10 localities across the Commonwealth to host listening sessions. We partnered with Black female legislators, free clinics, Alpha Kappa Alpha sorority, and United Way of Southwest Virginia, and many, many more, to bring together community organizations, local healthcare providers, hospital systems, local state officials, to hear the powerful, moving stories of courage and resilience of the many families who had suffered so much. I was amazed by this generous gift that they gave us and what it cost them to share those very personal and traumatic stories with the public. We knew it was vital to have their input, their community-led solutions and strategies to improve maternal fetal health across the Commonwealth. So these sessions became our maternal health strategic plan for achieving the governor's goal to address the racial disparity in maternal health outcomes that President Rowe mentioned. And here's some of what we learned. Individual systemic and structural racism and bias is negatively impacting the healthcare environment and maternal health outcomes. Healthy pregnancies start with healthy individuals even prior to pregnancy. Women and families want more choices for maternal care providers and support teams, and our current reimbursement models do not allow for a full range of choices that reflect who they are and what they need. We need policies and practices that make women feel less fearful of seeking vital prenatal and postpartum care. There's a need for mental health trauma screenings in prenatal and postpartum periods, especially more care and services for that postpartum period. Again, solutions must be community-driven and community-specific with partners who are trusted and respected. So we put our money where our heart is, and we included substantial investments in maternal health in our budget to get us started. Over $13,000 to cover substance use disorder treatment, $1.2 million for community doulas, $137,000 to provide 12 months prescriptions of contraceptives for Medicaid members, with an additional $1 million for long-acting reversible contraception. In April, our office will roll out the governor's maternal health strategic plan, which will provide a roadmap for Virginia providers and policymakers to eliminate the racial disparity in maternal health outcomes by 2025. This is a bold goal, but we know it is one whose time has come and one we know that together we can achieve. As Malala Yousafzai says, I raise my voice not so that I can shout, but so that those without a voice can be heard. We cannot succeed when half of us are held back. I thank you so much for your time, your care and commitment to mothers and babies, and I look forward to hearing from our wonderful panel today. Thank you all so very much.
Thank you very much, First Lady Mrs. Northam. We really appreciate your remarks today. And to President Rowe for joining us with that brilliant introduction. It's great to hear that William & Mary is wearing masks and doing so much to ensure that the pandemic doesn't spread anymore. So my name is Rachel Becker. I serve as the policy advisor to the Secretary of Health and Human Resources here in the Governor's Office of Virginia. And I graduated from William & Mary in 2019. And one of the large parts of my policy portfolio is supporting the governor's maternal health initiatives. So I'll be moderating this panel. And I wanted to say a huge thank you to Dr. Vanessa Walker Harris, who is the Deputy Secretary of Health and Human Resources for serving, as well as Kelly Cannon, who serves as the Director of Population Health for the Virginia Hospital and Healthcare Association, Dr. Camille Hammond, who is the CEO of the CADE Foundation, and to Professor Claire Mckinney, who serves as the Reproductive Justice Professor at William & Mary. So really looking forward to diving into this topic. I just want to give just some quick brief background, some more of the data that President Rowe and the First Lady mentioned. So while the United States has one of the most technologically advanced healthcare systems in the world and should be able to ensure the delivery of safe, high quality maternity care, the maternal mortality rate remains stubbornly high. In 2018, the US maternal mortality rate was 17.4 deaths per 100,000 live births, totaling 658 deaths total. This is higher than most other developed and high income countries. Data shows that as many as 2/3 of pregnancy-related deaths are preventable. Moreover, for every maternal death, many more women experience serious complications around the time of delivery, known as severe maternal mortality. So nationally and here in Virginia, it is striking that the maternal mortality rate is 2 to 3 times higher for Black women. And this is what we're going to be exploring today and finding out what are the best ways we can reverse these trends. So what I'm going to do now is hand it over to our amazing health experts and our panelists, who will give us just a quick round of tell us a little bit about yourselves, how your work touches maternal health, and why this field of work speaks to you. And I'm going to start with Kelly Cannon, if that's all right. You're closest to me, who's the Director of Population Health at the Virginia Hospital and Healthcare Association. Go ahead, Kelly.
Thanks, Rachel. Good afternoon, everyone. I'm always proud to start off an introduction by saying I'm a William & Mary alum, class of 2005, and very happy to see my freshman roommate has joined us as well. As Rachel said, I work for the Virginia Hospital and Healthcare Association. So we're the industry association that represents the 26 health systems and 110 hospitals in Virginia. Or most importantly, we have approximately 50 birthing hospitals in the Commonwealth. So I get to work with all of them in a variety of ways in this role. One of the most important is that we operate a maternal health collaborative, which is funded through the Virginia Department of Health and the Virginia Neonatal Perinatal Collaborative. Right now, we're working with 9 hospitals who have very specific quality improvement programs dedicated to improving the maternal health outcomes in their communities. So they're partnering with community-based organizations to help patients access resources to address their health-related social needs. They're monitoring their chronic conditions, their mental health, and helping them with everything they need. So that's a new initiative that we started about a year ago, right before COVID hit. And when I called all these hospitals and as the pandemic started and said, do we need to hit a pause on this project? They said it's more important than ever. So I'm really excited to share a little more about what hospitals are doing. I'm also, this work is important to me because I'm the mother of 2. And I've been pregnant 3 times. So I miscarried once. I had some very scary and challenging pregnancies, and fortunately easy deliveries. So I'm just really committed to helping more women in the Commonwealth deliver their babies safely. Thanks, Rachel.
I'm going to throw it over to Dr. Vanessa Walker Harris, the Deputy Secretary of Health and Human Resources.
Thank you, Rachel. Very much appreciate the opportunity to join you on the panel today. So as mentioned, I serve as Deputy Secretary of Health and Human Resources for the Commonwealth, which means I provide support to a number of state agencies, including Virginia State Medicaid, the Department of Behavioral Health and Developmental Services, and the Department of Health. And essentially, my goal in supporting these agencies is to help increase equitable access to high quality healthcare, particularly for persons in Virginia who are low income, disabled, or elderly. And the work that each of the agencies does includes ensuring that there is great access to high quality care for pregnant and parenting persons. We've learned a lot of lessons through the pandemic, in particular about insurance coverage and access. We know that insurance coverage is not the end all be all, but it is a first step, a very important first step in order to getting folks into seeking that clinical care. And so the Department of Medical Assistance Services, Virginia State Medicaid, has been able to leverage flexibilities from the federal government to make sure that that coverage is expanded and the way we provide services is expanded. So as has been mentioned, we're now expanding coverage from 60 days postpartum to full 12 months. We know that the majority of maternal deaths occur within that 43 to 365 days. So 60 days just isn't quite enough coverage to help moms and babies. And then we're leveraging flexibilities about how we provide care, like through telehealth. And so that has been a great opportunity. Along with remote patient monitoring, there was legislation this session to increase access to remote patient monitoring, particularly for high-risk pregnancies. And so I would say, similar to the work done by Virginia State Medicaid, each of our agencies are working to make sure we're leveraging flexibilities and providing good access to pregnant and parenting persons. A lot of that work is also done at the Department of Health through their home visiting programs, their Title X family planning to provide reproductive access out to the community, and particularly persons who are low income, and a number of nutrition support programs. We know that the clinical care is just one piece, but there is a lot of life that impacts our health going into pregnancy and throughout pregnancy, like transportation, food access, housing. And so our agencies are working to make great gains in each of those areas. And I am personally connected to this work. Reproductive justice is a value, along with equity, that I personally hold. And so it's really an honor to be able to do work that's aligned with those values.
Thank you, Vanessa. And now I'm going to send it over to Dr. Camille Hammond. Do you mind giving us a little bit about yourself and how you touch maternal health and why this work speaks to you?
Well, thank you so much for having me. And I want to say I didn't go to William and Mary, but I did go to school in Virginia. I'm an alumnus of the University of Richmond. So a little bit of spider action there. I'm so happy to be here today. My work really involves supporting families with infertility. So I guess you could call me pre-maternal health because I work to support those families who struggle to conceive. The definition of infertility is not getting pregnant after 12 months of unprotected sex for women who are 35 and under, and 6 months for those who are over 35. Our work really involves sharing about the different pathways to parenthood, which can include different types of fertility treatment, adoption, and also we do provide ongoing support to those after they've conceived and even become parents, because infertility, unfortunately, is something that just stays with you. That experience is something that stays with you. The foundation gives out grants of up to $10,000 per family to help with overcoming infertility. And we have given out about $1.3 million to support families throughout the country, as well as, or in particular, to families in the state of Virginia. So really pleased to be here. Thank you for having me.
Last but not least, Professor Mckinney.
Hi, everyone. I'm completely humbled to be on this panel with such extraordinary folks. I am an assistant professor at William and Mary in the government department in the Gender, Sexuality, and Women's Studies program, and my research focuses on reproductive politics in the United States. My research begins in thinking about abortion politics, which, if anybody knows, in the United States are quite extraordinary, both for their polarization and the ongoing contentiousness of those politics. But that research very quickly leads us into thinking about everything that goes into those politics, including thinking about forced sterilization, thinking about access to sterilization and birth control, and ultimately access to supportive maternal care. So I teach a class on the politics of reproduction and have so over the past several years that really delves into thinking about the lifespan of reproduction, from questions about access to consensual sexual activity all the way through access to welfare and state support postnatally. And so I think thinking about that lifespan altogether is really important for us to have a real conceptual understanding of how people experience reproduction and really their freedom in relationship to this fundamental human activity.
Thank you, Professor Mckinney, and the rest of our panelists. That's a perfect segue into my first question, and I'm going to kick it to you, Professor Mckinney. So can you explain a little bit of how did we get here? Can you shed light on the historical and academic perspective / context on the maternal mortality crisis in the US?
Yeah, so we typically kind of start this by thinking about what were things like in 1900, which sounds like a long time ago, but in 1900, somewhere between 800 to 1,000 women per 100,000 would die in childbirth. So up to 1 in 100 women would die in childbirth, which is really incredibly shocking. But this sort of crisis wasn't really on the international scene until about 1985, where the focus kind of shifted from infant mortality to thinking about maternal mortality. And in 1985, approximately 500,000 women and pregnant people would die annually from obstetric complications globally. As has been mentioned by President Rowe and Rachel and others, the US still remains at the highest end for high-income countries in terms of maternal mortality. So we have more than double the rate of the next high-income country, which is France. So France has had about 8.7 per deaths per 100,000, while America has ranged between 17.4 to 23.8 per 100,000. The other statistic that I feel is really shocking is that over the past 10 years, US maternal mortality rates have actually been increasing while those rates have been decreasing worldwide. And so the United States really is facing a crisis by any international measure. The other thing to note is that the majority, a slight majority, 52% of US maternal deaths happen after birth. So as others have mentioned, this isn't just a question of access to prenatal care, but also about postnatal follow-up. So how do we treat women and post-pregnant people after birth to make sure that they have access to all the care that they need? How do we think about the postnatal experience as part of this picture? And that really kind of brings up a lot of the issues about access to healthcare that I feel like Virginia is, one of the states that we should be really proud about putting this front and center. More than anything, obviously, is that racial disparities drive the overall US disparity. Black women die twice as often as white women, as other people have mentioned in the US. In Virginia, that rate is even higher, where Black women are 3 times as likely to die from pregnancy complication and post-birth complications. And identifying the causes of these disparities and addressing them has been a priority in Virginia, which puts it well ahead of the state that I'm a native of, which is Texas, where maternal mortality rates continue to increase without any state action. And so our expansion of Medicaid has been very important. The other initiatives described by the other panelists have been crucial to this. And this isn't just a US phenomenon, thinking about the racial disparities. So in the UK, Black women are actually 5 times as likely to die from pregnancy complications as white women. So that's even greater a disparity than the United States. So this is a global problem that requires real deep thinking. This isn't just about addressing access to healthcare. In Britain, there is the NHS, the National Health System. We don't have universal healthcare, and they still have these disparities. So we do need to think about other ways that race relates to broader experiences. including how racial bias works in healthcare, thinking about health or food insecurity, thinking about geographic determinants of stress and access, and questions of ill health. And so I think that all of that is part of the comprehensive picture that is confronting practitioners today.
Thank you so much, Professor McKinney, for your profound words. I was taking notes as fast as I could. And you mentioned the social determinants of health and the importance of postnatal follow-up in improving our maternal health outcomes. And that leads me to my next question to Dr. Walker-Harris, which is, what do you see as the major barriers for individuals and families seeking maternal and postpartum care and services in Virginia?
Sure, thank you for the question. And really, my comments will dovetail with what Professor McKinney has shared in that, access is one step, meaning insurance coverage. And so as Professor McKinney noted, Virginia has made gains in improving access to insurance with Medicaid expansion, with the elimination of 40 quarters, which impacts immigrants who are attempting to access insurance. And so our bar in Virginia was much higher than the federal bar, and we tacked on several additional years before immigrants could qualify for Medicaid. And now we're rolling back that policy to make the entry into Medicaid easier. And then the expansion of services, making sure we're covering services that would be helpful to support healthy outcomes for pregnancy. One such services, doulas, which I may touch on a bit later, but definitely wanted to say that in addition to access, is making sure the folks who are providing care are providing culturally humble care. So they have an open mind to understanding their patients as persons. They have an open mind to learning about other cultures and perspectives, so that any inherent biases that we have, and we all do have biases, don't negatively impact the care that's provided and negatively impact on maternal and infant health outcomes. And then I would say, working as far upstream as possible, we really have to remember that the doctor-patient relationship, that in-clinic visit, only controls about 10% of your health. And then the rest of it is what happens outside of those four walls in the community, meaning we do have to be serious and intentional in acting to make sure that there's access to transportation, to nutritious food, safe space for physical activity. It's a challenge when we're recommending, particular weights entering into your birth experience if someone doesn't have access to safe physical space to exercise, or can't afford nutritious foods, and their communities mostly just have fast food or corner stores that don't provide those healthy options. And then again, it can't be overstated, the impact of structural and systemic racism, and really considering our opportunity in all of our spheres of influence to do equity audits on the policies that are in practice, so that we can better hardwire treatment algorithms and decision pathways, and make it less likely that human choices or human biases can negatively impact care.
Thank you, Dr. Walker-Harris, for your insight. As I'm not sure if I've told this panel, but Dr. Walker-Harris is actually my boss, so thank you for being here and for your brilliant words of wisdom. You mentioned the word doula, and that's something that you and I talk about all the time. Virginia just co-led and finished the doula Medicaid benefit implementation work group, which was included in the governor's budget. So we're really excited to implement the doula benefit now that, fingers crossed, we do get authority from the General Assembly once the governor signs the budget to move forward. But that's something that we're used to saying, but could you talk about a little bit of what is a doula? What is the benefit of doula services? And how is Virginia increasing access to doula services?
Sure, thank you for those questions. And so doulas are community members. They're not medical professionals, but they're community members who are bought into the idea that pregnant people need support, and in order to navigate the healthcare system, to advocate better for themselves. And so that's what they do in supporting pregnant persons and their family members, is to navigate that healthcare system, help the pregnant persons advocate for themselves, speak up and ask questions and better understand the information they're receiving in that clinical space. And some pregnant persons choose a doula during just the prenatal portion and then will deliver their baby in a hospital. Some pregnant persons choose the doula and intend to have a home or birthing center birth, but it's really about providing another set of eyes and ears, and someone who is adept at navigating the system, and not just the healthcare system, but identifying needs and then getting that pregnant person connected to resources in the community, to the point that's been previously made. If there are gaps around food or housing or transportation or childcare, then the doula is able to connect with healthcare providers, other systems of resources and care, to make sure that the pregnant person gets wraparound support, and increases the likelihood of those good pregnancy outcomes. We know that the American College of Obstetrics and Gynecology supports birthing support persons, including doulas, as a best practice in getting pregnant persons sufficient support. And so Virginia, as you've mentioned, is bought into this as well, and initiated a doula benefit work group so that we could identify what would be a reasonable and living wage to compensate these community members for their excellent work. And now we're awaiting, as you noted, a final approval to go through those administrative changes with Virginia State Medicaid and final approval of the budget. But we're very excited about providing greater access to this to community members, particularly those for whom it's been a barrier. Cost has been a barrier because there hasn't been that insurance coverage for it.
Thank you, Vanessa. And I know we've been talking a lot about Virginia specific, but the proposed rates out of the doula study that we led last fall are the highest reimbursement rates in the country. So it's really exciting stuff. There was an article recently that Virginia is the most progressive state in the South. So lots of movement coming out of the Virginia government. I'm going to shift the focus of and I'm seeing questions in the chat, so please keep putting them in there. We'll get to them. I just have a few more prepared ones. I'd like to shift the topic a little bit because we're talking about interventions and reversing these trends. And I'd like to speak more with our healthcare providers, our care setting, Kelly Cannon and Dr. Hammond with us here. So Dr. Hammond, can you speak about the journey and the barriers, both medical and cultural, that women of color have in navigating infertility and family building?
Absolutely. So just kind of a baseline, 1 in 8 families struggle to get pregnant. That's infertility. African Americans, unlike the myth, which would suggest that Blacks are super fertile, African Americans are less likely to conceive. When they go, they're less likely to go to fertility treatments or to even express their concerns about not conceiving to their doctor. When they have treatment, they're less likely to get pregnant. And then when they conceive, they're less likely to deliver a healthy baby. And then we've already talked about some of the negative maternal health outcomes. So across the board, Black women suffer the least desirable outcomes of any group. And there are many, many factors that contribute to that. We've talked about structural racism. We also have to talk about access to resources, whether it be money, whether it be insurance, or just knowledge about where care is available. There are also some cultural issues at play where there's less kind of a foundation of community awareness about medical treatment for fertility that may be considered more experimental, and there is a lot of fear of the medical world because of past historical abuses such as Tuskegee and even Henrietta Lacks, what happened with her. So I think all of these factors really do contribute to Black women being less likely to report for care and less likely to receive the same care that their peers may receive. The question is, what can we do about it? We've got to address each issue. I think starting at the community level, working on addressing myths and also just sharing the truth. And it can't just start with the person. You've got to start even with the faith part of the community, because so often when in the Black community, many people rely on their faith for kind of grounding and guidance. And so when a woman is diagnosed with infertility and she goes to her pastor, and the pastor really doesn't know anything about infertility, they may give advice that is not medical and that goes against the patient's best interest. Even if you decide you don't want to have fertility treatment, there's nothing wrong with going to your doctor to understand the cause of the infertility, because it may be something that's hormonal and easily fixable. And for some reason, fertility is treated differently than many other medical conditions. If a person said, I've lost a lot of weight, I don't know what I should do, they would be told immediately, well, go talk to your doctor. They can help you figure out what's going on. But if they say, well, it's been 5 years and I haven't gotten pregnant, more often they're told, well, wait on the Lord, and maybe he'll answer your call. So we got to do better with educating the community and also educating patients about resources. There are many times where people live in states where there are mandates, where they are required, the state legislature has actually required insurers to provide coverage for the diagnosis and treatment, or even a part of diagnosis or treatment. And the person may not even know that they have that coverage. There may be a lack of knowledge about that. And then so often women self-select out of the treatment pathway. So they may say, well, fertility treatment, if I decide to go forward with that, that's going to be $15,000, and I don't have $15,000 set aside. So I'm not going to even pursue that, not understanding, it might not be $15,000. There are grants. There may be some type of health benefit available. Some clinics have sliding scale payment opportunities, not to mention, there are just a number of resources that may be available to help. But if people select out before they even present to the clinic, those things aren't even possible.
Thank you, Dr. Hammond. And I really appreciate what you said earlier about being pre-health and maternal health. It's really nice to have all the different perspectives here represented. So my next question, still related to the care setting, is for you, Kelly. Can you speak to some of the ways we can help raise awareness among healthcare providers and health system executives about the poor maternal health outcomes related to the care setting specifically? Dr. Walker-Harris noted that only 10% of healthcare is with your provider. So can you speak to, in that 10%, how we can be more engaged?
Absolutely. So I mentioned earlier a partnership with the Virginia Neonatal Perinatal Collaborative, which is a network of providers that is working on evidence-based, data-driven approach to improving maternal health outcomes. One of the projects that we're taking on this year, we actually just inked our agreement, we're working on that this week, is to roll out the CDC's Locate tool, which is levels of care assessment tool. So I'm sure a number of us are familiar with NICU levels or trauma levels for hospitals. So you know that if there's a major car accident, the patients will be transported to a trauma level 1 hospital, like VCU here in Richmond. Their NICU levels 1, 2, 3, and 4 being the most specialty services available to treat neonatal infants. What the CDC has proposed and what we'll be starting to roll out with Virginia hospitals is the Locate tool, which will help us better identify maternal health services and help providers, OBs, better connect their patients with the hospitals that can provide them the best level of care. So a high-risk pregnancy that has specific comorbidities related to cardiac, for example, needs to be at a hospital that has the specialists that are ready to serve them. So that's something we'll be working on over the next year. Is it involves hospitals doing self-assessments, their communities and local health departments also participating in the assessments and ultimately publicizing those levels. I recently had a friend who called me from the emergency room saying, I'm 23 weeks pregnant and I think we're ready. I think we might be delivering this baby, and am I at the right hospital? And we kind of navigated that together, but that we know that that information should be more publicly available. And that's something we're really gonna be working hard with our hospitals to do. Some of the other initiatives that we've taken on, Delegate a majority leader, Charneil Herring, just passed a bill, and we're hoping that the governor will get to sign it soon. It was passed unanimously, so I feel pretty good about our chances, to create a maternal health data task force, and to spend the next year really studying the data. There's a wide range of data available that, to speak to a lot of the statistics that we heard earlier coming from the maternal mortality review team and others, but there's not been a really comprehensive look at pulling all of that together and deciding what we can do to actually improve health outcomes. So I think that's going to be a really important collaborative effort between providers as well as state leaders in the coming year to collect that data and analyze it more clearly. On the provider side, I mentioned our maternal health collaborative. We have 9 hospitals participating now, and our goal is over the next 5 years to have all birthing hospitals participate. We start small, when a group of them at a time, so that they can have a lot of engagement within the group. But we actually this year are expanding more of our trainings to all birthing hospitals. So we're conducting webinars with national experts. And Dr. Hammond, I'm going to be following up with you because I really want to get you in with my group, to talk about topics like implicit bias training and make sure we're doing all we can to address the racial inequities that do exist within maternal mortality in a very focused and meaningful way, and find ways that we can make improvements. And then lastly is I focus a lot on data because that's something that we can provide, as my association can provide out to our members, and we're finding that it helps to drive changes, that there's been a lot more focus on that. So we have this maternal health dashboard internally that we're actually this year adding. I saw a question in the chat. We're adding a COVID flag to any mothers who were diagnosed with COVID during their pregnancy, and we'll be doing a lot more tracking of the impact of that diagnosis and that infection on their pregnancy, on their health outcomes, and on their baby's outcomes as well. One of the flags that will be included in that dashboard that we'll release publicly later on this year is the mental health impact that a COVID-19 diagnosis has on a expectant mother. I can tell you, as somebody, I gave birth in January of 2020, back when we thought having a baby in flu season was scary, and I think I have probably participated in about a dozen different studies and research groups, and really watching closely what the impact of the pandemic has been just on my personal experience. And I've shared those surveys out with a number of other folks and through our hospitals as well.
Thank you, Kelly. And I really appreciate the personal anecdotes, because it's so, I think often, especially as policymakers, it's so easy to talk about our numbers and our figures and our data, and it helps inform our work, but there's people behind these numbers. And it's really nice to remind ourselves that these are real stories, and they're impacting all of us, even the ones that are working in this work. So we did get a question in the chat. I'm going to move more into our chat questions. We've got about 10 minutes left, and I just want to make sure that we are respectful of everyone's time. So one of the questions that was brought up is the scarcity of OBGYNs in rural areas. And so the first question is, does Virginia face these challenges as well? And then how can doulas or other maybe midwives or other practitioners help fill these gaps? And then part of that question, I think, kind of comes off of is how can we improve the healthcare workforce pipeline? That was something that the First Lady mentioned that we heard in our listening sessions, is the importance of having healthcare providers that reflect our patients and reflect our patient population. So I'm going to start with Dr. Walker-Harris, if you wouldn't mind speaking to the scarcity of OB providers in Virginia.
Sure. So I don't have that data at my fingertips, but I do understand that nationally we are headed towards an OB provider shortage. And so leveraging the expertise of mid-level providers like midwives is going to be key. And there were a number of bills this past session to increase the opportunity for certified nurse midwives, for certified midwives in supporting birthing persons and families. And one of the bills included a study for all of the different types of midwives to make sure that we're appropriately regulating them, and they're able to work to the top of their license. So the certified nurse midwives, certified midwives, and certified professional midwives. So looking forward to the work that comes out of that study. And to the point of doulas as well, being on that team. And there are a number of different members on the birthing team. It might be a lactation consultant in the postpartum period, and others that would provide who provide great support to pregnant persons, postpartum persons, and their families, and making sure that outcomes are healthy. But to the point of provider shortage areas, that data is collected both by the Virginia Department of Health, the Office of Health Equity, and the Department of Health Professions in order to ensure that we're supportive of programs like loan repayment or grants or otherwise for designated health professional shortage areas to draw folks into those areas so that the community is well resourced. And I forgot the second part of the question, Rachel.
I'm talking about diversifying the healthcare workforce.
Great, awesome, thank you for jogging my memory. So, right, we know that outcomes are better when care is racially concordant, but African Americans make up, I think, only about 5% of all physicians across the nation. And so we do have work to do there. And I think in part, who seeks a career in medicine and who seeks a career either in primary care practice or obstetrics can be influenced by what your financial status is for your family and for you personally. So I think making sure that all stages of higher education are affordable so that people who are interested and committed to this work have that opportunity and won't incur significant debt that then further impacts their decision making when they go out into practice. I think that's an area of opportunity. And then, of course, there are lots of different models for pipeline development, working with kids as early as elementary and middle school, providing them with those opportunities for internships and research so that they stay well supported and are able to navigate the path all the way to becoming a nurse practitioner or a physician or at all associated with healthcare and able to provide services out to the community. I find historically Black colleges and universities have done a phenomenal job at pushing folks into careers as physicians and as researchers. And then there are a number of historically white institutions that are also doing a great job of supporting their students of color and pushing them towards graduate degrees in fields such as medicine.
And I'm gonna, if it's okay, pick on Dr. Hammond, if you wouldn't mind kind of speaking to what you think the role as a doctor yourself, and you're a practitioner, correct?
I don't practice anymore, but I am a physician.
Okay. Could you speak a little bit on maybe the role of medical schools in improving the diversity of the healthcare workforce, and if there have been classes on racial bias or implicit bias, and classes perhaps on maternal health outcomes and that sort of thing?
So I know that just yesterday, maybe 2 days ago, there was an explosion where JAMA was trending because one of the editors said that physicians couldn't be racist and that structural racism in medicine wasn't a thing. And of course, they retracted that and apologized, and there's going to be some follow-up. But when you have one of the leading journals in medicine and one of their editors come out and say that racism is no longer a thing because it was outlawed in the 60s, you realize there's a lot of work. We still have a lot of work to do. So I think that I went to medical school. I graduated in 2000. So it's been a few minutes since I went to medical school, but I know that when I went to school, diversity was important. It was a value. It was something that we talked about. We talked about health disparities, the causes of the health disparities, and students were challenged to look at their own biases and to try, you can't remove them, but to try and acknowledge and address them intentionally as they interacted with patients. I think, you know, if you pretend like something doesn't exist, then you're never going to address it. So it's going to be important for all of these schools, whether it's an undergraduate institution that is really preparing students for medicine and healthcare, or a medical program, that they really give attention to these issues, training and provide an opportunity for honest dialogue. I think that is going to be one of the important ways to resolve the issue.
Thank you, Dr. Hammond. And I'm going to go over to Kelly, who can speak perhaps on more of the healthcare setting side. So do you think that healthcare providers, in your experience, will be open to accepting implicit bias as a core part of this problem? Like Dr. Hammond had mentioned, the JAMA article, is this something that you're hearing in the hospital space, especially given that hospitals often are the centers of community, and especially for community care?
It's absolutely something that we are working with our hospitals to roll out to staff in a number of departments. And ultimately, the goal would be that all medical providers would receive that kind of training. I mentioned my foundation operates a number of collaboratives. Another one is hospital-based violence intervention programs. So working with trauma hospitals and the care that we're providing to victims of violence, connecting them with resources beyond their hospital time. And next week, actually, all of our funded staff in those programs are going to be undergoing implicit bias training through the Virginia Center for Inclusive Communities. And that's one that we're hoping to roll out with our maternal health collaborative in the coming year, and then continue to expand to additional departments. I want to also mention that I've seen some great comments in the chat, and then Dr. Walker-Harris, I've got an idea after this. So over the past year, so in November of 2019, Governor Northam kicked off the Virginia Healthcare Workforce Advisory Council. And that group, I had the pleasure of staffing along with Dr. Megan Healy, who's the governor's chief workforce advisor, and who led that along with Steve Arner from Carilion Clinic. That group ended up obviously focusing over the year of 2020 almost entirely on COVID impact on the healthcare workforce, specifically the shortages of nursing and certified nurse assistants. But I think that we have an opportunity in the next year, perhaps, to specifically address the shortages in the maternal health provider space and do some more work there. So I'm kind of excited for that follow-up and take home from this. I hadn't thought about what the next iteration of that group would be, and I think we have a great opportunity for some workforce HHR crossover efforts.
Sounds great. I'm looking forward to that discussion.
Well, thank you all so much. I think my kind of last question, if we could just do kind of a quick lightning round, because I know we've only got 2 minutes left. And please, if the panelists are willing to leave their emails in the chat in case there's follow-up questions, or I can just leave mine and I'm happy to email them out and help get answers. We had lots of activity in the chat, and I'm hoping we covered a lot of the topics that were brought up. But just like a quick lightning round question is, how can we continue to raise awareness of this crisis? Not just in the United States, but also in Virginia, in our own communities. How can we keep shedding light? And I'm going to start with you, Professor Mckinney, because I feel that I've neglected you on this panel. So if you wouldn't mind going first.
I think you've addressed the questions to the people who are best served to answer them. So I really appreciate all the insight we've gotten from everybody so far. You know, there have been some questions in the chat of how we can attune our attention to the people who need the attention the most. And the number one thing on my agenda is to just, you know, continue to listen to those who are at the forefront of these efforts. And so in the activist space, the organization that comes to mind for me, that is a national organization, is the Sister Song Collective, which came up with a very, you know, coined the term of reproductive justice, which is, you know, this idea that we should think about you know, reproduction, not just as having children, but it's, you know, the right to maintain personal bodily autonomy, to have children, to not have children, and to parent children in safe and sustainable communities. And so if, you know, we continue to attune ourselves to listening to the voices of those who are most affected by disparities in care, then I think that that will help us come up with collective solutions that will allow us to kind of flourish as communities. So I'm so excited by everything that's going on in Virginia. I think it's a model of how we can continue these efforts in really progressive and transformative ways.
Thank you so much, Professor McKinney. If we could also all just sit in on one of your classes, I think we'd all appreciate that, all 300 of these participants. And then I'm going to go to Dr. Hammond. How can we continue to raise awareness and address this crisis?
I think two things. Number one, we can work to affirm women and remind them that their voice is important. And if something doesn't feel right, that they have the right to seek care and to seek answers from other people, other resources. You're not committed to one set of providers for the rest of your life. So I think we need to empower women. And then I think we need to work with our healthcare providers. So often, not so often, but sometimes doctors are under tremendous pressure to move very quickly through patients, and someone may not get the time and attention that they need so that they can really tell you what's going on. And so, we need to continue to remind physicians to listen to women. When she tells you that she doesn't feel like something is right, don't just say, it's probably fine, come back in 6 months. Listen to her. So I think if we work on those areas, many of these changes hopefully will be possible.
Thank you, Dr. Hammond, and thank you for your time today. I know that I will definitely be following up with you about some of our Virginia maternal health efforts, so be on the lookout for that. Okay, Dr. Walker-Harris, how can we continue to raise awareness?
I really echo what has already been said by these esteemed and very impressive panelists, and would also say to encourage women to speak up. I've been really leaning into a quote by Audre Lorde that says, when we are paraphrasing, when we are silent, when we speak, we're afraid that our words will not be well received. And when we are silent, we are still afraid. So it's better just to speak. And so to the point of empowering, encouraging them to speak up, and not just women who are coming forward seeking help, but for each of us in our own spheres of influence. If you see or have an idea about a change that will help to, mitigate implicit bias or policies that might be privileging one group over another, then speak up in that instance as well.
Thank you. And then Kelly, how can we continue to raise awareness?
Well, I love the theme of these comments about speaking up. And I think it's really important that we continue to create space as women to talk about these issues. So I was thrilled when Val said that she had the highest sign up for this topic. And it doesn't surprise me that William & Mary women would want to jump in, but reaching out to your friends, talking about these topics is incredibly important. Also researching in your community. I've learned through my collaborative a number of really amazing local providers that are offering doula services and home visiting and material resources to women and families in need. So research those and by all means get involved. We actually have, just here in my neighborhood, every week someone is collecting baby supplies and dropping them off with little hands in order to get them out to folks, especially that started off in the pandemic, and I hope it's something we'll continue to do. So we really look forward to continuing these conversations, and don't hesitate to reach out to any one of us. I'm going to say for all the panelists, certainly for me, would love to hear about your experiences with hospitals, and we're going to keep working hard to do better.
Thank you, Kelly. So that wraps up our panel for today. Just huge thank you for all of our health experts, and to the Hulan Willis Society and the Society of 1918 for their support in creating this event. And big thank you to President Rowe and the First Lady of Virginia for their opening remarks. And now I'm going to pass it over to Val Cushman, who will give us our closing and give some more information. Thank you all for joining us.
Wow. That word keeps coming to mind. Gosh, on behalf of all of our participants today in the William & Mary Alumni Association, Thanks so much to President Rowe, First Lady Northam, Dr. Walker Harris, Dr. Hammond, Professor Mckinney, Kelly Cannon, and an extra special thanks to Rachel Becker, who you all should know was the motivator, creator, and moderator for this program. So thanks to you all. And thanks to all of our registrants. I mean, a big shout out to all of our participants who shared rich information with one another via the chat, demonstrating the power and the collective impact of William & Mary women amongst each other and the greater good. So as I shared in the beginning of the program, today is the first of a three-part series on women's health. Our next program will focus actually on breast cancer and will be held on April 7th at 4 o'clock. And there too, sadly, we'll be exploring the health disparities for women of color as it relates to breast cancer survival rates. And we will close the series with President Rowe and her sister, Dr. Susanna Rowe, on practices and policies in the workplace that inhibit or support the health of their employees. So the next Society of 1918 event is slated for next Thursday, and I hope you'll join us for that as well. Next Thursday, we'll celebrate, in conjunction with Virginia Women's Veteran Week, William & Mary women who serve in the military. We have an amazing collection of 4 women, our highest ranking woman who has served, and a current student cadet at William & Mary who serves. So we will be celebrating women's service and recognizing all those William & Mary women who do serve in the military. If you're interested in engaging with the Society of 1918 or our Hulan Willis Association, please do reach out to one of what we call the Vals, Val Cushman or Val Wilkins, who is the lead for our Hulan Willis Association. And the easiest thing to do is use the email address ideas@wm.edu. We'd love to hear your ideas about future programs. We'd love to hear you if you'd like to raise your hand to take part in leading or being a part of creating them. So with that, I will say again, thank you to our panelists. Thanks to everyone for joining us today. Please do be well, and everyone have a great night.